Yes, good evening, everybody. Good evening, Dr. Aarti. Yes. So let's get started. So this is a session based for our targeting the INICET. So few weeks before, we did the INICET important question predictor series also. Yes, right? Good evening, so everybody. Accordingly, based on those topics only, let us discuss few questions related to that topic. So let us get started with the first question here. So 5 questions from nephrology, 5 from rheumatology, based on what we discussed. So typically, one of the common topics in nephrology is to ask about the metabolic bone disease. Is the metabolic bone disease. So please everyone, today we are just discussing the questions, high yield questions. You can watch the previous video also where I have discussed these topics more in detail. So 1 hour respiratory medicine, nephrology, rheumatology video is also there in the previous one, right? Today we are focusing on 2 subjects, nephrology and rheumatology, 5 questions each. So when a patient of CKD presents to the nephrology clinic with the bone pains, what we are suspecting? We are suspecting CKD associated metabolic bone disease. In the patient having CKD associated metabolic bone disease, what are you expecting? Which are the true statement about this condition? So we know there are 3 types of metabolic bone disease in CKD. The first type is the osteitis cystica fibrosa. This osteitis cystica fibrosa occurs mainly due to development of hypocalcemia, which is associated with hypercalciphosphatemia. Associated with the hyperphosphatemia is present. Hyperphosphatemia is present, which incidentally leads to the elevated PTH level. Elevated PTH level leading to the defect, that is osteitis cystica fibrosa, is going to be present. So definitely patient will have hypocalcemia, patient will have elevated PTH level, but there is no hypophosphatemia. Remember, when hypophosphatemia is associated with hypocalcemia, it always indicates a nutritional defect. It always indicates a nutritional defect. In CKD, there is a defect in excretion of phosphate. That is why hyperphosphatemia is there. But even before the hyperphosphatemia occurs, the earliest one is the elevated FGF23. The FGF23 is the regulator. FGF23 is the regulator of phosphate metabolism. Regulator of phosphate metabolism. And that is why, like PTH, it is also a sensitive marker. That is an early marker that phosphate is increasing. Early marker that phosphate in the blood is increasing. So in modern practice, in all patients, we don't only check the calcium and phosphate. We also check for the PTH level. We can check for FGF23 level also. So the correct answer is option number C. That is 1, 3 and 4. Correct. Very good. So bringing us to second question. Acute renal failure or acute kidney injury is diagnosed by the following criteria except for. So now we know for diagnosis of the acute kidney injury, we have adopted the KD-IGO criteria. Out of the KD-IGO criteria, any one has to be present to confirm diagnosis of AK. So we can say if the urine output is less than 0.5 mg/ml per kg per hour for 6 consecutive hours. That's why we get the question that the minimum duration, minimum time to confirm the diagnosis, minimum time to confirm AKI is 6 hours. The minimum time required to confirm the diagnosis of AKI is 6 hours. Rise in creatinine also by more than 0.3 from the baseline within 48 hours. 1.5 time within 7 days confirms it is AKI, except EGFR less than 60. EGFR less than 60 for more than 3 months duration is diagnostic of the CKD. It is used for diagnostic of chronic kidney disease. So EGFR less than 60 ml per minute for more than 3 months is used for diagnosis of the CKD. CKD, of course, also can be confirmed if any specific symptom is present. So, or for CKD, we want any one or more of the specific feature present. Specific findings of CKD we must use to confirm the CKD diagnosis. So that has also come in MCQ, that which features are considered specific of CKD. So when the patient has got loss of the CMD, when the patient has got shrunken kidney on the ultrasound, then definitely it is CKD, or there is presence of a broad waxy cast in the urine, or there is presence of metabolic bone disease. Metabolic bone disease, all these are specific finding of the CKD, which either can be used to confirm diagnosis of the disease. Right? Take it forward to the third question. When a 60-year-old female presents with ischemic cardiomyopathy in chronic heart failure. So the key word here is patient is in chronic heart failure. This chronic heart failure is going to be risk factor, we will say, is chronic hypoperfusion is occurring. There is a chronic hypoperfusion is occurring. Patient presented with complaints of nausea and vomiting. What you will say? Patient has got uremic symptom. But what I always say, in the diagnosis, the hypoperfusion is the risk factor present in this case. The patient has presented with uremia, which told me there is renal dysfunction is present. But along with that, I also saw grade 2 pedal edema, elevated JVP, again heart failure only. But sodium, there is got dilutional hyponatremia is present. There is the dilutional hyponatremia is present in the patient with heart failure. But the creatinine has increased to 2. Creatinine has increased to 2. So along with urea, elevated serum creatinine. Okay, so correct answer, is it B or C? Answer, increased in the creatinine confirms there is renal dysfunction. GFR has become low. GFR has become low. But in GFR low, we have to identify where is the problem. You have to identify where is the problem in the kidney. The most common site is the tubular necrosis. It could be the acute interstitial nephritis, or it could be rarely the glomerulonephritis. I want you to tell me, among the three, what will happen to the value of FeNA? FeNA is the fractional excretion of sodium in the urine. What will be the value which can help detect the site of the AKI? Help detect the site of AKI, because pre-renal is also there. So what we will say? In ATM, the FeNA is more than 4%. In interstitial nephritis, it is mild, 2 to 4%. It is relatively milder, but rarely in GN, it can be preserved less than 1%. It can be preserved less than 4%, which mimics pre-renal also, which can come in pre-renal also. So here the key finding in the patient is patient has got urine sodium is high and the FeNA is more than 5%. Because the FeNA is more than 5% and there is hypoperfusion, we can say most likely answer is acute tubular necrosis. Most likely answer is acute tubular necrosis. So you can ask, why is it not pre-renal? Because in pre-renal, the FeNA is always less than 1%. That's why not pre-renal. Glomerulonephritis also, FeNA can be less than. Anyway, heart failure is not a risk factor. Heart failure is not a risk factor for GN and definitely not post-renal. Again, no risk factor of obstruction is given. Correct answer is B, acute tubular necrosis. So just remember this point. ATM, AIM, GN or pre-renal. FeNA is a sensitive marker. But as always, the focus of the question remains on the glomerulonephritis, which is one of the most important topic. So these are the common causes that we can say. IgA nephropathy, let me put it down for you. IgA nephropathy is the most common cause of nephritic syndrome in the world. The post-streptococcal GN is the most common cause of nephritic syndrome in our country. The lupus nephritis is the most common autoimmune cause. The most common autoimmune cause of nephritic syndrome. The vasculitis are a group of autoimmune disease which are typically ANCA-mediated vasculitis. And we have got the good posture, which is least common cause, only 1 to 3% of the case. All of them can present with nephritic syndrome. Membranous is a rare cause of nephrotic syndrome. Rare cause of the nephrotic syndrome. Now, these are the choices that we have to choose. So we will take two case scenario to discuss these two topics. That out of these questions, options of GN, which one will be the correct answer in the first scenario? So out of this above scenario, identify most probable cause from the above answer list. Here, a patient is a 45-year-old male who has presented with the symptom cough with hemoptysis. So cough with hemoptysis indicates the patient is having pulmonary involvement is present. Very good. Along with pulmonary involvement, the urine also shows the dysmorphic RBC and cast. So along with pulmonary involvement, there is GN also. That's why we put them under the heading that it is one of the pulmonary renal syndrome. It is the diagnosis has to be among one of the pulmonary renal syndrome. But along with that, patient is having a skin rash is present. Now when skin rash is present, problem along with the skin rash, it favors the diagnosis of vasculitis. It indicates there is vasculitis. So from the list that we have been given, like it came in this year's exam also, you only have to choose the diagnosis here is one of the vasculitis syndrome. But as you have rightly answered out of that, whenever patient has got foreign body sensation in eye, ocular involvement present, is always pathognomic of vaginal. Is always going to be pathognomic of vaginous. So I tell you that in exam, the questions will be relatively easy only. Nephrology, rheumatology, both are relatively super specialty topic. Even in INCT, you are going to get basic level clinical question, which you don't want to miss. Okay. So we got here diagnosis is vaginal granulomatosis. From list, it is just vasculitis syndrome. Okay. Last one for our nephrology. So here, when patient come with cough and sore throat with dysmorphic RBC. So patient has got sore throat and also is having glomerulonephritis. Then we know patient is having post-pharyngitic GM. Patient is a case of post-pharyngitic GM. In the post-pharyngitic GM, answer could be IgA or Berger's disease also, or it could be a case of PSGM, or it could be a case of PSGM. But how will you differentiate between the two? So IgA nephropathy typically affect young male is affected. In this patient, the latent period is less than 1 week. So from the time of sore throat and hematuria, the time gap is less than 1 week. These patients have normal complement levels because activation is by complement mechanism. There is elevated IgA1 level in the patient, and this has got least risk of RPGM, less than 1% risk of RPGM, making it the best prognosis. Making it the best prognosis. But the close differential which we compare PSGM. PSGM is a disease affecting school-going children. Disease affecting school-going children. Latent period is longer than the Berger's disease. Here, complement level is initially low, both in infective and autoimmune disease. Complement is low. Most common antibody is the anti-DNase antibody, more than ASO positive. There is only 1 to 5% RPGM risk. So the prognosis is the second best. So both the post-pharyngitic are relatively young patient, and relatively good prognosis is there. So this question you get, read what is matching. Here the patient is school-going person. Presentation is nephritic feature. There is hypertension also, and complement level is low. And that is why best diagnosis is the PSG. Best diagnosis in this case is PSG. So two set of questions always you remember. In glomerulonephritis, one is pulmonary renal syndrome. Second combination is post-pharyngitic GM. Repeated every year, similar questions only are coming. So, chalo, let us move ahead to just recall some point from rheumatology. Rheumatology also, again I am going to just review this question with the update. So you tell, when a 20-year-old lady, first is our age and epidemiology. Age and epidemiology also tells me young female is come with history of oral ulcer, which is not responding to the B complex injection. Can you tell me what are the various autoimmune diseases? What are autoimmune causes of the oral ulcers? If patient is having oral ulcer, not responding to B complex, first is after excluding the nutritional causes. What is remaining? You have got autoimmune cause. Autoimmune cause can be both SLE also, but let's not forget Behçet's disease also. Both can be there. SLE is definitely more common. Behçet's also is a possibility where there can be mucocutaneous presentation. It can also come with the mucocutaneous presentation. Behçet's also can be there. Very good. SLE, Behçet's. Correct. But she complains of non-specific symptom, easy fatigability since the past 2 months. Answer could be both. So we know fever and low-grade fever also favors only what? That it is autoimmune pathology. That's all I know. So in autoimmune pathology, following finding are expected except for. So just look at, we don't know the cause. But in autoimmune pathology, what can you expect? You can definitely expect autoantibody present. The presence of autoantibody can be present. So can there be positive anti-DCT. DCT is basically anti-erythrocyte, which can be seen with few patients of SLE. Possible. High complement level never occurs. Never occurs. The autoimmune disease always have got persistently low complement level. Autoimmune disease have got persistently low complement level because there is a lifelong inflammation is present. Lifelong inflammation is there. So it is going to be persistently low complement level is going to be present. In the SLE update, which are the two drugs that have come? Just recall them. In the SLE updates 2024, which are the two new drugs that we want to remember? For example, one is the IV anifrolumab. One is the IV anifrolumab. You want to remember. This IV anifrolumab is monoclonal antibody against the interferon type 1 receptor. Interferon type 1 receptor. And the other drug that has come, oral voclosporin. Voclosporin is a calcineurin inhibitor. So this also can be given. This also can be given for the maintenance of severe cases. For maintenance in the severe cases, we can go for oral voclosporin. So belimumab, your rituximab, they were already present. Okay, they were already present. Now two drugs have come. Anifrolumab for crisis, oral voclosporin for maintenance in severe case. Yeah, that's what we want to remember about the SLE. Remember about the SLE. Okay, take it forward. Identify this sign. Identify this sign. What is the point we want to highlight here? Identify the sign. Direct answer. Tell me what I want to focus on. Important topics. Gottren's rash. When you get a maculopapular rash, it is described as a maculopapular rash over the MCP joint, metacarpophalangeal joint. The presence of Gottren's rash is characteristic. It is diagnostic virtually. It is characteristic of dermatomyositis. It is characteristic of dermatomyositis. It is going to be dermatomyositis. In the dermatomyositis, which are the other areas of rash that can occur? The other areas involved with the skin rash can be over the eyelids, can be over the neck area and over the back area. So we have given that in the name. Over the eyelid, the patient of dermatomyositis can come with the heliotropic rash. Over the neck, if it is there, we call it the V sign. Over the back, it is present, we call it the shawl sign. But what I want you to know, which is the most specific antibody, for the Gotran's rash, even though it is only 10 to 12% sensitive. 10 to 12% sensitive. The new antibody that has come, we have got the anti-MI2 antibody. Anti-MI2 antibody. MI stand for muscle inflammation 2. The most specific antibody discovered, added to our list, anti-MI2 antibody can be present. Jo is possible. So how we have to say? Comparison. The anti-Jo can be present, but it is most specific for the polymyositis. The anti-Jo is most specific for the polymyositis. It may be present in the dermato also, but the most specific for dermato today is the anti-MI, muscle inflammation 2, is going to be present. New antibody, remember this for now. Anti-Jo is there, more specific for polymyositis. In dermato also, anti-Jo can be there. But how it is? Like in SLE we study. In SLE, what we do in practice? dsDNA. But most specific will be anti-Smith. Like that, in dermatomyositis, we do anti-Jo, routinely available. This one is the most specific antibody that is associated with dermatomyositis. That's what I wanted to add here. Take this forward. Anti-Ro antibody are present in all the condition except for. So in our revision, we did all about the antibody in our rheumatology. So anti-Ro antibody is present in all except for. Tell me role also. It is present in SLE. In SLE, it has got prognostic value. It has got prognostic value. It crosses the placenta and causes congenital SLE, increases the risk of congenital SLE. But on the other hand, it is also protective against the maternal nephritis. It increases the risk of the congenital SLE, but it is protective against the nephritis. In Sjogren's syndrome, it is both the diagnostic and prognostic. It is both diagnostic and prognostic. In the Sika syndrome, it is both diagnostic and prognostic. In neonatal SL lupus also, anti-Ro is the responsible antibody, is the only antibody in SLE to cross the placenta. So if there is congenital, there has to be anti-Ro, has to be present only. But in MCTD, that's not the problem. In MCTD person, what will they have? For screening, they have both ANA and RA factor. They are both ANA and RA factor positive. But the most specific antibody is the anti-U1-RNP. Is the anti-U1-RNP is present in patient with MCTD. Present in the MCTD. Done? So antibody and their role. Few are diagnostic, few are prognostic, and some are only for both. That is why we must know them. we discussed again. Please watch video. Those who have not, I want you to go back to them. And most specific antibody to diagnose rheumatoid arthritis is our anti-CCP. The anti-CCP is both diagnostic and prognostic. It is both diagnostic and prognostic in RA because it is associated with increased risk of bone erosion and joint deformity. It is both diagnostic and prognostic in patient with rheumatoid arthritis. While remember, what is RA factor? RA factor is the both screening antibody. The screening antibody and prognostic antibody in RA. It also tells me increased risk of bone erosions. Screening because it is most common antibody. But again question, what is RA factor? It is a IgM type of antibody directed against the Fc portion of IgG. It is the IgM type of antibody against the Fc portion of IgG. Even though we use it for the diagnosis, the problem, it has got many false positive causes. The problem is it is sensitive but not specific. There are many false positive causes. False positive, it can occur in the infections. It can be false positive in infection. Example, RA factor can come positive in infective endocarditis. We study one of the Duke's criteria, arthralgia with false positive RA factor. It can come in other autoimmune disease also, like SLE. Also sometimes it may be false positive. And it can be false positive in the inflammatory conditions. In the inflammatory conditions like infectious mononucleosis. The infectious mononucleosis, it can be the false positive also. Can be false positive also. Can be present. Right? So it is all, rheumatology is mainly about matching the disease with antibody. That's the main focus. Disease with antibody is the main focus. Bringing us to the last one, assertion and reason type of question. Assertion and reason type of question. The last one in today's class. But again, what is important? In the management of severe rheumatoid arthritis, mainly I'm trying to ask you here, severe means what? When the patient is having, suppose, case of DMARD failure. Suppose the patient is having DMARD failure. We are going to enumerate what drugs are there. So is belimumab one of them? Is belimumab one of them? No. So belimumab is not one of them. Assertion is false. But is belimumab an oral JAK inhibitor? That is also false. So what we will say? Both assertion and reason are false. Both assertion and reason are false. See, reason independently. ये क्या पूछ रहे हैं? belimumab oral JAK inhibitor है क्या? सिर्फ मैं बोलता था ओरल जैक इनहिबिटर गिव्स इंड्यूसेस रेमिशन, ट्रू हो सकता है, बट बेलीमुमैब ओरल जैक है क्या? नहीं. बेलीमुमैब इज अ एंटी बैफ बी सेल एक्टिवेशन फैक्टर. इट इज एन एंटीबॉडी अगेंस्ट बी सेल एक्टिवेशन फैक्टर which is used in the refractory crisis of SLE. Refractory SLE crisis, I can give the anti-B cell therapy. That is anti-B cell activation factor. But before we close, quickly tell me, in DMARD failure, what can we give? We can give both biologicals and we can give immunologicals. Among the biological, you will always prefer anti-TNF alpha agent first. First is the anti-TNF alpha drug. But not working, we can also go for immunological. Go for the immunologicals also can be used. In immunological, we have got both tofacitinib and the baricitinib. So it is the tinib which are used as our immunological tyrosine kinase inhibitors. They are used as the tyrosine kinase inhibitor can be given. Of course, IL-1, IL-6, anakinra also correct answer. Most preferred are anti-TNF alpha. Right. So Jat boy is really on fire. So right answers. So I'm very happy that all of you are prepared. Remember, in the day of exam, the most single important prognostic factor. I tell you what is prognostic factor. But today listen, in exam, the single most important poor prognostic factor. In the exam, single most poor prognostic factor in the exam is anxiety. Okay, so we have to try to overcome as much as possible. There is a thin red line between feeling little bit, what we call apprehension. Anybody will face newness, exam I am giving first time. But anxiety है ना, killer है. And best हमारा कौन है prognosis? Best prognosis is prognostic factor is logic. Opposite of anxiety is the logic and calm. As I always say, in MCQ based exam, the answer is one of the options in front of you. But many times you will relate to this. Many times when we come out of the exam hall, we feel, अरे यार, I knew this answer, फिर भी मैंने silly mistake किया. वो silly mistake क्यों होता है ना? Because of anxiety. But थोड़ा सा logic रखेंगे ना, तो हमें सही आंसर चूज करने का बेटर आउटकम हो. सो जितना भी होगा, सी ऑलवेज उसके लिए हम क्या बोलते हैं? वे बिफोर द एग्जाम, उसी लिए क्या कहते हैं? बिफोर द एग्जाम. क्या करना है? मतलब अभी बिफोर द एग्जाम you must study, you must put in your best heart as if you know nothing, as if you know nothing. You are having no knowledge, so that you use to motivate you before the exam. But on the day of exam, what you want to do? Go as if you know everything. So go tell yourself, give yourself that positive feedback that I know everything. Because on the day of exam, खुद को बुरा मान के क्या अचीव कर सकते हैं? कुछ नहीं. जो करना था कर लिया. So हमेशा याद रखना, be nice to yourself. On day of exam, positive mindset बहुत जरूरी होता है. You will get couple of questions maybe where you will not get answer. But don't get demoralized. There are always going to be 10-20% of questions. But those questions don't bring down your percentile. Because tough questions, many students will not know. It is answering the correctly, the simple question that decide your rank. Because tough question nahi aaya, everybody ko nahi aaya. But easy question nahi aaya, many other got right. That's when your rank goes down. So don't get stressed on those 10% rare question. जो किसी को नहीं आएगा. That's not our lookout. Our lookout is to make sure कि जो टॉपिक मुझे पता है आने वाला, उसमें मैं गलत ना करके आऊं. That logic will help you and get you through the exam with flying color. चलो, all the very best. ज्यादा टाइम नहीं लूंगा. एग्जाम टाइम है. टाइम इज वेरी प्रेशियस रिसोर्स. पॉइंट टू पॉइंट रखेंगे. चलो, गुड नाइट एवरीबॉडी. ऑल द वेरी बेस्ट फॉर द अपकमिंग एग्जाम.